Good morning. I'm Rick Croskery. I'm an internist here locally, and it's my honor to introduce you to Dr. Eugene Furth. I think a slide is going to be coming up. It's not on the screen. What do I do? Actually, it's one. Experiencing technical difficulties. Plug in projector. There we go. There we go. Gene was a lifelong scholar, a dedicated teacher, skilled healer, an astute administrator, respected leader, an innovative scientist, and the very best of colleagues. His educational work history is listed here, and I just want you to note he went back into training as a fellow in geriatrics after he had been chair of our department for 10 years, a lifelong learner. He's the reason I'm here. In 1980, when I was a senior medical student at The Ohio State University, I told our chair, Dr. Calvin Kunin, of my plans to make a trip south to interview at MCV and UNC and Bowman Gray. And he said, well, there's a brand new program down there at East Carolina, and the chair there trained with me at Cornell. He's a great guy, and I'm sure he's putting together a good program. So why don't you go down there and look at it and come back and tell me about it? Well, I liked it. I matched, and here I am. I hear stories like mine all the time. And in addition to residents like me, Gene recruited faculty who never left. For instance, Harry Adams. Okay, get it off of there. I went back one. There we go. We residents pictured Dr. Furth in the days of yore. He's on the left there, probably carrying tubes of blood in his pocket of his barber shirt, identifying dyslipidemias by visual inspection, working 72-hour shifts in gloomy institutions where they used lightning rods to power their experiments, having to work Christmas in the wards with the nurses and the lab rats. But he was a great example to us in clinical medicine also. For instance, he took service call just like everyone else. His wife Mary told me he hated the monkey suit, and on evenings like this was glad to have an excuse to go to the emergency room. He made time to relax and have fun, too. Everyone looked forward to the Furth's annual pig pickin'. For most of us, it was our introduction to this peculiarly East Carolinian ritual, a convivial gathering of faculty, private practice, and physicians in training. And every summer they had a Department of Medicine sailing regatta with the house staff serving as crew on the faculty's boats. The morning report with Dr. Furth is the highlight of your training, where the house staff discusses each day's admissions, resuscitations, and deaths. We learned there were not only successful and unsuccessful resuscitations, but sometimes successful deaths. Whether we ended up in general practice like I did or in subspecialties, private practice or academics, Furth-trained physicians learned the satisfaction of listening to and examining the patient and processing the clues in our computers to make the correct diagnosis and put that diagnosis into the context of the patient's life. We also learned the science of medicine was important, and even if we didn't have the pedigree of Harvard or Duke, we could have our own research day, so we started one. Here are a few Furth pearls. Patient comes first. Doctors should teach. There's joy in patient care. Dr. Furth was not just the chair of medicine, but also teaching faculty in his specialty, shown here contributing to gland research in the Division of Endocrinology and Metabolism. And as the chief, faculty often called upon him at his office to request space, resources, staffing, or funding, and were handled in his unique way, such as being directed to the prayer bench. My recently retired partner, Rob Turner, told me that Dr. Furth could attentively hear your request, tell you no, and escort you out so skillfully you actually felt good about it. That's just the kind of man he was, a friend to all, great and small. I called him a few years ago to ask him if he would be willing to be nominated to succeed me as president of the Pitt County Medical Society. I was pretty nervous asking my mentor and someone of his stature to take on yet another responsibility. But he said, "Rickery, how could I say no to you? You've done so much for our community." And he went on to serve the medical society as president with distinction. He loved medicine, his students, his residents, his staff, his faculty, and his community. And with fondness and respect, so we remember his legacy in this lectureship. A few years ago, when Mary downsized their house, she invited me to have a few of Gene's books, and I selected a couple that are in my library. In celebration of today's lecture on the treatment of hypothyroidism, I would like to donate this one back to the division. This is Gene Furth's copy of the World Health Organization, 1960, on endemic goiter. Gene's favorite word. There you go, Al.
Thank you. No, I'm trying to get the introductory slides. Dr. Hunter, if you could help me just a second, because it should have popped up, but it didn't come in the right order. I'm going to just minimize that. If you could bring up yeah. Thank you. Yes. Good morning. It is both my pleasure and honor to introduce our 2014 Furth lecturer, Dr. Mohammed Shakir. Dr. Shakir and I go quite a ways back. I would like to acknowledge Dr. Shakir as my mentor for these past 25 years, and I still consider Dr. Shakir my mentor and probably the best that there's been. Dr. Shakir did his early training in India. He came to the United States, did his internal medicine residency in New Jersey, and then did fellowships in endocrinology with the National Institute of Health, both in Little Rock, Arkansas, and then at Johns Hopkins University. Dr. Shakir came into the military and has since then held numerous academic positions in the military, including being the division chief of endocrinology at Bethesda Naval Hospital for many years and the program director where he trained and mentored a whole generation of endocrinologists for both the military and individuals who've gone out into civilian practice since that time. And that's a very important contribution. But Dr. Shakir currently serves as the consultant staff for the Division of Endocrinology at the National Military Medical Center, now called Walter Reed National Military Medical Center, since they've combined the institutions. And he's also a professor of clinical medicine at the Uniformed Services University of the Health Sciences. Dr. Shakir has won numerous awards, but I want to mention a couple that are quite notable. One, he is a Master of the American College of Physicians and a Master of the American College of Endocrinology, and has been recognized as Teacher of the Year by the American College of Physicians. Dr. Shakir has a long list of publications, a couple of which are listed here. I want to mention the fact that also over the past 12 years, very pertinent to the talk today, he's been heavily involved in important research at the National Military Medical Center looking at T4 thyroid hormone replacement versus combined T4 and T3 replacement, and also investigating T4 replacement versus Armour thyroid extract replacement, which has opened some new questions about thyroid hormone replacement therapy. And without further ado, Dr. Shakir is going to present to us today Hypothyroidism and Controversies in Treatment. Welcome, Dr. Shakir. Thank you.
Morning. Thank you for your kind words, Dr. Drake. And it's an honor and privilege to be here. And before I start my lecture, I had to tell one story about Dr. Drake. Hope you don't mind. Now, you all know him as a professor and a big person here. And one Friday evening around 6:30 or 7 o'clock, Friday, I got a consult to see an osteoporosis patient with some spinal osteoporotic fractures. So I asked Dr. Drake, do you mind going and seeing patient? Of course, I will go and see. And it was 7 o'clock. I waited till 8:30, 9 o'clock. He still is with the patient. So I go there, walk, and then he was doing complete neurological examination on this patient, pinprick, vibration, and all those things. So I asked, why you had to do all these things? It's just osteoporosis. Oh, no, I had to do a complete physical examination. And this is Dr. Drake. 9:30, 10 o'clock. And he's the only one. Of course, in the military in those days, we can order the fellows to do a lot of, it is not the 80 hours. So we can order a lot of things. So he's the only one I had to practically order 2 days a week, working days. Please go home by 6 o'clock. Because he's there till 9 or 10 o'clock in the night, all the time. And by 3 o'clock or 3:30 in the afternoon, one good thing I still miss him is he brings green apples. And then he peels them very nicely, cut into pieces, keep it on his table. And I used to go around 3:30 and sneak in and get 2 or 3 pieces. Now I don't get any more of that. So today I'm going to talk on hypothyroidism. And this is, do you know where this is? Which country? Anyone? Pardon? Tibet. This is in Tibet. And so this is the winter palace of Dalai Lama, who was kicked out by the communists in China. And he's in India right now. And this is the winter palace. And there are about 634 steps to go all the way. So I was planning to go up, then I asked him, if I get a MI, what happens? Sir, you have to be carried back on a wheelchair or on a chair or a stretcher. So I changed my mind. So this is the Shangri-La, and there's a book called Lost Horizon. If any one of you have read, it is a very nice book. And it's written by James Hilton. And they made a movie 1933 and again another movie in 1973, and this is everlasting life once you go to Shangri-La. So there are some anti-aging, in fact there is a board for anti-aging medicine now. I think it is run by from California, green growth hormone, all those things. So could you do this everlasting with thyroid hormone treatment? Not necessarily, but still this is one of the earliest picture of hypothyroidism, and when you treat it, there's some hair growth and there's some rejuvenation. But don't expect this to happen in all your patients. And this is another one, serial old picture. You can see the hypothyroidism developing, and you can see the puffy eyelids, loss of the lateral 1/3 of the eyebrow, the coarse hairs, and all those things. Now my talk today is going to involve in the causes, treatment, some aspects of the history of thyroid hormones, then desiccated thyroid extract, and finally future possibilities. So this is a very, very common disease. The prevalence is around 4%. It's more common in women than men, around 4 out of 1,000, whereas in men it is about 6 out of 10,000. And levothyroxine is the most common prescribed after aspirin and simvastatin in the United States. So it's a very, very common drug. So how good are the symptoms of hypothyroidism? They are very bad, really. In fact, one of my own family members, I missed the hypothyroidism. I think Dr. Drake knows who it is. I felt so bad. So the sensitivity of the symptoms is around 4%, 2.9 to 25%. If you have more symptoms, there are more increased symptoms. So even if it is absent, you cannot exclude it. We have seen pilots, we have seen commanding officers coming with TSH of 60, 70, 90, miss the diagnosis. And the symptoms are non-specific. And if you go and ask the patient, I don't know about the Washington area compared to here. All the Washington area patients have fatigue. And I stopped asking the question, fatigue. Do you have fatigue? You have to document, then you have to work up that. So I stopped doing all that workup. And so you really have to do the diagnosis. And I personally believe TSH is the best way to make the diagnosis. You can ask all the questions you want. You cannot make a clinical diagnosis. This is one area I don't think clinical medicine is very good. You don't have to agree with me. So, few definitions. Overt primary hypothyroidism is elevated TSH and low free T4. And subclinical is elevated TSH, normal T4. 95% of the normal healthy adults have TSH levels between 1 and 2.5. Only 5% is on the low side, 5% is on the high side. And there's a shift of this in the elderly population, and I'm going to come to that a little bit. In people over the age of 65, it shifts to the right. So if you have a 75 or 80-year-old person, TSH up to 7.58 is normal for them. And don't treat an elderly person with a TSH of 8 unless very strong antibodies are positive or low free T4. And genetic factors can also affect TSH. In fact, that's one of the things Dr. Drake was doing some studies at the academy, doing bone densities. We were planning to look at the TSH over a couple of years, and we didn't completely do all the workup. Each one of us have their own TSH, and that's the way it is maintained, whether it's different. And I think probably this is the genetic influence is doing that. Now, do you know who this is? I don't think you'll remember that. This is the famous Dr. Calvin Kentel, and who got the Nobel Prize in 1950 for inventing adrenocortical hormones. And once he invented, all rheumatoid arthritis patients got the steroids. And he's only, he's a PhD, and he was in Mayo Clinic. He synthesized the thyroxine crystals at the age of 28 years. And at 65, he then moved to Princeton, and he died in 1972. So again, the history is, remember, Kentel crystallized at the age of 28 years. Murray is the first one to inject thyroid hormone. That's a sheep thyroid gland extract. Only in 1952, Gross and Pitts River identified the T3, 1958. So this is the first paper by Murray, and it is published in 1891. He took the sheep thyroid gland and then mixed with glycerin and carbolic acid. Do you know what is carbolic acid? That's a phenol. And then that's the way you sterilize it. Then inject it between the loose skin of the back, between the shoulder blades. Is a convenient situation to make the injection. And carbolic acid is very, very painful. It's like injecting alcohol into subcutaneously, so you can imagine. But the patient felt much better. So normal thyroid gland has 200 micrograms of thyroid hormone per gram of the tissue and approximately 15 micrograms of T3. And the circulation ratio of the two hormones do not represent what is in the thyroid gland. Interestingly, 80% of the thyroid T3 is made in the liver, and some from the intestine and the kidney, 80%. 20% comes directly from thyroid gland. So if you look at it, normal human body don't do these things without a very good cause. And I think we are not smart enough sometimes to figure it out. And there is a reason why the thyroid secretes 20%. So when you give T4, you expect the liver to mimic this one. So that 20% contribution from the thyroid gland is gone. And a lot of times when you do not know, you think, that's the way it is. And for example, if you look at the textbook of physiology, written, edited by Best and Taylor in 1960s, the mentioned lymphocytes very clearly says lymphocytes are circulating cells with no known function. So you can imagine about that. So this is the structure, and usually we use pyroxene sodium. That's the one in synthroid because that's soluble. Pure thyroxine is very difficult to dissolve. This is some of the synthetic one, and T4 is the one used. 70 to 80% is absorbed in the small intestine. Half-life is 6 days. 80% I mentioned comes from peripheral conversion. And usually the level is very steady state. And these are the two pathways. This is the T4 is converted to, if you remember, two D1 and T2 enzymes are the one activates into activated compound, and D3 is the one which inactivates the enzymes. And this D2 and D1 are the most important one to activate, and that probably determines some of the functions of how patients are doing it. And this is the Tang dynasty built this fort in China. I visited Xi'an for an endocrine meeting there. And communists, one thing they were very smart is they did not destroy a lot of things. Compared to, I think in Soviet they destroyed a lot of things compared to here. And this fort is very beautiful, really. And this is the terracotta warriors. This is all built and kept in a museum. It is in the same place. Amazingly, if you take out these soldiers out of this place, they go downhill very fast. And you have to keep in that place. That's the only way you can preserve them. And this is again a plasma TV on the roof of a shopping mall. And you can see that fish swimming on the top. It's amazing technology. And this is, then I went to Tibet, and this is the lake in Lhasa, around 17,000 feet high. And fortunately, I didn't get mountain sickness. So, usually you can give oral thyroxine for all the patients, and also you can give it for hypothyroidism due to surgery, and average dose is 1.6 to 1.7 micrograms per kilogram body weight. And thyroid hormones exert the effects by crossing the cell membrane, binding to the nucleus, and affecting the gene transcription of messenger RNA. And effects of grapefruit juice on the absorption of thyroxine. You have endocrine fellows who can answer this question, what happened with grapefruit juice? And you have to tell me the mechanism. Why? Who can answer that? Dr. Drake, you're the chief, so the fellows are not answering. Okay. So if you look at the clear empty circles, that's the one with thyroxine taken with water. The absorption is fairly good. The dark circles is with the grapefruit juice. So there is a decrease if you take it with thyroxine, grapefruit juice. Interferes with the absorption. And the mechanism is the transporters. There are several transporters like organic anion transporting polypeptides, and there is a sodium taurocholate co-transporting peptides, monocarboxylase, and actually grapefruits affects one of these transporters. This organic anion transporting polypeptide, that's its effect. Cyclosporin also affects it. So this is something very important and interesting to know that. So I will go through some of the pharmacokinetics, and this is renal insufficiency. There's a reduction in total T4, total and free T3. Free T4 is less affected. Severe liver disease, total T4 and free T4 may be elevated. Total T3 may decrease. And soybean, papaya, grapefruit juice, and coffee can interfere with thyroxine absorption. So coffee, that's important to remember it. Site of absorption is in the jejunum and ileum. Bioavailability is 70-80%. Tmax is 2 to 3 hours. And if you look at it, almost all the T4 and T3 are bound. T4 is half-life, T half-life is 6 days in euthyroid patients, prolonged in hypothyroid. And for T3, it's only 1 day, 1.4 in hypothyroid patients. Pregnancy. We all know that as soon as you get pregnant, thyroid binding globulin goes up, and the T4 level, total T4 level goes up. And there is an increase of thyroid hormone production by 20 to 40% in pregnancy. And this is the reason why pregnant patients who are hypothyroid, you have to increase the thyroid hormone by 40%. And we usually do it by giving 2 extra pills per week. That is, if they are taking, say, 100 micrograms every day, instead of the 7 tablets, we double the dose on Saturday and Sunday. And obesity. This is something very interesting because you have a very good department doing a lot of bariatric surgery. TSH could be elevated, and this is the leptin has some action on the pituitary gland, and leptin interacts with the TSH. And TSH may be elevated without detecting thyroid antibodies in this patient. So it is not a autoimmune disease. And that may be something very interesting. You know, if you have they follow some patients in pediatric surgery before and after looking at thyroid functions. And T4 can be up or down depending on which review you read. I mentioned again the elderly population, the metabolism of T4 and T3 are reduced and reverse T3 increases. T4 half-life is prolonged, 9.3 days. H. pylori and absorption, lactose intolerance, atrophic gastritis, IBD, all this can affect. So if we have problems, we usually look at these patients, we do check for celiac disease, some of these patients. And these are the drugs. TSH secretion is affected by octreotide, glucocorticoids, and dopamine. All these three drugs are used in the ICU setup. So usually I tell the fellows best is not to check thyroid functions. Yes, if you check, then it's a big problem. Sentinel hypothyroidism, all those things. And lithium iodine, all this, know that. And in this, other absorption, cholestyramine is one drug, and we have done some work on cholestyramine. And actually, cholestyramine can be used in some patients with Graves' disease and also for iatrogenic hyperthyroidism. For example, 50 milligrams of cholestyramine can bind to 3,000 micrograms of T4. There's an enterohepatic circulation. So it's a very good drug, you can use it as long as they can stand constipation and nausea associated with the use of this drug. And all the other drugs, you all know, I'm not going to go through this list. Each time I had to look at it and remember. Amiodarone is a very common drug, and cardiologists use it, and they produce the hyperthyroidism, then they refer to us, and we are stuck with those patients. Very, very difficult to treat these patients. And again, if you look at this, the dose is usually hydrocortisone, more than 100 milligrams per day, and furosemide is high dose can do it, affect thyroid functions. So usually there are several preparations. One is synthetic thyroid or sodium thyroxine, and it comes in different trade names, Synthroid, Levoxyl, and generic version. T3 or Cytomel, and there's a combination of T4 and T3, that's the Thyrola, and finally desiccated thyroid extract. And soft gel capsules is a tyrosine. Tyrosine is also available in other countries as drops, which you can use for pediatric patients, and also in solution form. So the bioequivalence is done by giving 600 micrograms of thyroxine. You give it as one dose, fairly big dose, then you do the serum levels. This is how the FDA has told we have to do the bioequivalence. They don't use the TSH or T3 to measure it. And and also the FDA has changed in 2007, the potency should be 95 to 105%. Before it was 90 to 110%. And if you look at some of the articles, there was big controversy, big political issue, New York Times, everyone writing about this levothyroxine bioequivalence at that time. So this is the summer palace of Dalai Lama. And I told you the winter palace is all the way up. I don't know why he has to go climb with the snow and other things all the way top. I would have changed the other way. And this is again used as a museum making money for the Chinese government. So now, proton pump inhibitors and levothyroxine. And normal pH is between 1 and 2.5 in the stomach. And in the jejunum and ileum, it is more alkaline pH. So if you give PPIs, what happened to the pH? It can be maintained usually between 5.1 and 4, or it is around 4. So the pH is not optimum for the absorption. So there are two studies, at least there are more studies. One is done by Saraceno. He gave tyrosine. That's the one in the oral solution. It comes in a glycerin preparation and in capsules. You can do this and bypass the absorption problem. So if they are on a lot of PPI and you really want to treat this patient, you can try the tyrosine. And so this is one looking at the dissolution of Synthroid, then generic version that's made by Sandoz and Pyroxene. So this is a very sensitive assay. They used inductively coupled plasma spectrometry. And if you look at it, the red is using the generic version. It's made by Sandoz. It did fairly well in this study, but the problem is if you write for a generic preparation, there's no guarantee you'll get the same 6 months later from the pharmacy. Actually, if you look at the distribution, between pH 4 and 6, the Synthroid is only about 20% dissolution, so it's not very good. So remember, the pH is between 4 and 5 with PPIs in the stomach. So whereas tyrosine did fairly well, still it's around 50% dissolution. Now, bariatric surgery, this is something. Bariatric surgery following, they may need increased doses of T4. It maybe has to do with the dissolution or rapid movements. I don't know the exact mechanism. And in this patient, tyrosine may be a good drug. And so this is the hotel I stayed in Tibet. You can look at all the mountains. So surprisingly, and this is another view of the summer palace of Dalai Lama. And in fact, Barack Obama, our president, is going to meet with him in the White House. And of course, China already made all the protests. And I was surprised in China, there's a mosque. And I visited that. This is around it was built in 1420. And it was built by the Tang dynasty. And he was very open. And there are churches, there are Buddhists, all these things. They didn't destroy any of those things. These are all the versions on the top is from the holy book in the mosque. And this is all carved in stone. It's all intact there. And this is the entrance to the mosque. The mosque is all the way at the back. It's a beautiful place. Actually, that city is very nice. It's called Muslim city in China. I was surprised. And they have Buddhists living in the monasteries. And as long as you don't look at the politics area, they are very happy. They don't miss you up. And coffee. As I remember, coffee interferes with the absorption. And how does the coffee do that? And this is one study it does. And this is done by Ben Wang studied. And his conclusion was coffee may retain the T4 within the intestinal lumen. So probably it binds to the T4 and make it impossible for absorption. So if you want to bypass this effect, and if you want to take coffee with thyroxine, you can use the tyrosine. That's the one in the capsules. And so you can do that. So you can write that prescription for tyrosine. The problem is I'm going to show the cost of tyrosine compared to the Synthroid. What's a good time to give levothyroxine? Ideally, we give between 30 and 45 minutes. But there are some studies shown, for example, Book give the medicine at bedtime and see whether that interferes with the absorption compared to taking it in the morning. So he found actually at bedtime it works much better, as reflected by a decrease in the TSH levels. And he extended that study to 105 patients and same conclusion. And retrospective study of 15 elderly patients, midnight versus 1 hour post-break, and TSH decreased slightly. That's all they found. And another study given 30 to 45 minutes at other times. So you can give tyrosine to bypass this effect. And this is one study done by Rajput, and he did not find much difference. Post-dinner, 2 hours. The problem with the post-dinner is what you eat for the post-dinner makes difference too. Who knows? If you take a lot of tofu, for example, soybean, or if you drink a lot of coffee, who knows? They may. And also if you take some medication, that may affect too. So, and this is one study in which if you look at the first line, and that's a baseline TSH. This is before breakfast and with breakfast. So my personal feeling is the best is They give it before breakfast, 30 to 45 minutes. And if they really want to drink coffee, if they want to spend money, Pyroxene is about $2.50 per tablet, per capsule, compared to Thyroid is about $1. And so $2.50 one Pyroxene cappuccino in Washington area is around $4. So you can spend $7 if you want to enjoy the cappuccino with Pyroxene. So it's much cheaper to take 30 or 45 minutes before. So T3 is available, and patients, these days patients are very used to internet. So they study, they print all these review articles and bring to you before they see you. So you have to be careful. T3 is usually used for myxedema, preparing patients for I-131, or sometimes to attain rapid euthyroidism. There is a preparation Thyroid which contains both T4 and T3, and a lot of patients don't like the treatment, Thyroid. Approximately it is around 15 or 20% of the patient, maybe 25%. And it could be under replaced. Some of the patients may be over replaced, and patients don't feel well. So that brings the issue T4 and T3 combination. Is there anything rational about it, or it is just crazy? Some endocrinologist saying this is a good medication. And the thing is, main feeling is people don't feel well, so let's add some T3. But if you look at the polymorphism, as I mentioned, conversion of T4 to T3 is depending on the D2 and D1. So if there is a polymorphism, if those things are not working very well, the enzyme converting dehydrogenase, there is a possibility the T3 may not be generated very well. The difficulty is you cannot measure that T3 by measuring the circulation. It is a tissue hypothyroidism. We don't have any good measurement for tissue hypothyroidism. And so T3, if you give T3, a lot of patients feel better. It may be possible, it may be crossing the blood-brain barrier, going to the brain. And T3 may act as a neurotransmitter. It may facilitate the actions of other neurotransmitters, and it has a positive effect of serotonin. So all these theoretical reasons suggest T3 may be a good medication. So if rats are made hypothyroid by thyroidectomy or by I-131, T4 monotherapy will not attain tissue hypothyroidism. Will not attain euthyroid in the tissues. So same way, this is the study. If you look at 25 to 32% of the patients, the T4 has to be on the high levels to normalize serum T3 levels. And same way, and if you give T4 only partial improvement of the neurocognitive studies. Again, these studies are not very sensitive to pick up the changes. So in one community study done by Saravan, 26%, 1 in 4 of the patients with normal TSH while on T4 monotherapy scored significantly worse than euthyroid controls on measures of well-being. So how do you measure it? Again, we have crude measurement. We wish we had a measurement for tissue hypothyroidism. In fact, Dr. Drake worked on looking at some nuclear receptors. We wanted to correlate. It didn't work out very well. But you can look at the mood, cognition, quality of life, patient preference, cardiovascular function and lipid profile, body weight, body composition, energy expenditure, sex hormone binding globulin. Sex hormone binding globulin you can measure because the main reason is it is an action on the liver. So you can look at it as a peripheral effect. But again, any of these studies, when you do the difficulty is you cannot just prospectively order 200 hypothyroid patients, you are going to take this study. And you advertise, and patients, when they come, itself there are some bias on selection. So this is one study, Benevicia studied, and he replaced 50 micrograms of the T4 by 12.5 micrograms of T3. And he included thyroid cancer patient who has more suppressed TSH. So this is not a very good study because thyroid cancer patients are completely different than the plain old-fashioned hypothyroidism. another study done by Sabaka. He studied 40 patients, and he only took idiopathic hypothyroidism or autoimmune hypothyroidism. He did not include post-thyroidectomy or radioactive iron treatment, and no improvement in depressive symptoms. Another study, this is done a detailed meta-analysis done by Grosinski and Glassberg. 1,216 patients. He measured all these things, scores. Depression, anxiety, fatigue, quality of life, adverse events did not differ, and he did not find any benefits. And this is a study done by Dr. Clyde. He was one of our fellows, and now he's my boss in our place. He treats me well, I have to say that. So 46 patients were studied. We gave T4 in capsules, T4 and T3 in capsules, and we found no benefits in these patients. And even preference was more towards T4 than T4 and T3. So this is another study by Escobar Morales. He did that, and there is some preference for combined therapy. And there are two other studies which shows some preference. This is one by Saravan and by Applehoff. And so again I mentioned D1 and D2, and if you look at the D2, that's an enzyme which is more in the central nervous system, and that's probably what determines the preference. Here, central nervous system D2. That's what probably determines the preference for these hormones. So, and there are some polymorphism. For example, there's a CC genotype of RS225014 in 16% of the patients. So 16%. So these patients may prefer T4, T3 combination. So if you look at the summary, there are 17 studies. I looked at all the summaries, and only few of them showed the benefit. So if you look at the mode cognition, beneficiary study showed, then Saravan study showed, and if you look at the patient preference, there are only 8 studies addressed it, only 4 studies showed the preference. So if you look at the patient's preference, if you look at it, it varied from 41% to 69%. So again, and body weight change, you lose about 1.7 kilograms when T4, T3. Of course, you can say that may be due to T3 overdosing. And no significant changes in the sex hormone binding globulin. So cholesterol, no changes in the cholesterol levels. So atrial arrhythmia is a possibility if you have an underlying heart disease in patient and over the age of 40 or 50. So probably polymorphism in the D2. That's the enzyme which is important in the central nervous system. Converting T4 to T3 may be very important in this patient. And D2 threonine, that is threonine 92 alanine polymorphism, is maybe very important. And already I mentioned about this gene RS22501, and that this patient shows great improvement. And this is done by Panikkar. This is done from England actually. So T4 T3 combination, hypothyroidism resulting from autoimmune thyroiditis, post-thyroidectomy, patient with D2 polymorphism, hypothyroid patient who have depression. But the problem is all the patients feel better the first 2 months. Only when you see sustained after 2 months, and especially after 6 months, you can really say it is working. So the new treatment of T4 and T3, one is customize the treatment with personal attention. What is the TLC, tender loving care? So you can give 3 doses, you can try to do it. But even 3 doses don't mimic the one in what the body is doing it. And there's a sustained release. There's some study going on. I think Washington, Ken Berman is doing some study. And genetic polymorphism, if they have the money to pay, it's not that very expensive to do this test. You'll be very surprised. You can do, I think, $100 or $200, you can do the test. So this is a monastery in Tibet, and you can see they go 3 or 4 times up and down, walking, and sometimes with 30 or 40 pounds in the back. And this is another, that's Summer Palace of Dalai Lama. So usually we measure 4 to 6 weeks, 6 to 8 weeks after giving thyroid hormone. but it may take up to 4 months for the thyrotropes to change to normal function. So now comes thyroid, desiccated thyroid extract. And remember, this is not kosher. It's made for pork thyroid gland. They take it and then they grind it, and it is made into a powder. In the old days, they used to look by the iodine content, but now they do the T4 and T3. And interestingly, this medicine is still available. The manufacturer continued to make it, and all the societies make fun of this medication. American Thyroid Association, Endocrine Society, and American Association of Clinical Endocrinology. If you give this, they think you are crazy endocrinologist. And there is even a site where they say this is the endocrinologist who will prescribe this medication. So, there are some studies since 1920, and one of the study was done by Jackson, and he looked at thyroid extract versus thyroxine, and he found the patients on thyroid extract has some degree of hyperthyroid symptoms. And next study was done by Clark Savin, and he also found some of the patients who were hyperthyroid, when changed to synthroid, they did better. But again, in 1978, the TSH lowest sensitivity level was less than 1.5. So you can imagine that's. And there is no T3 available. We didn't do routinely T3, no free T4. And so since 1978, there are no studies except comparing T4 versus thyroid extract. And in the days of evidence-based medicine, we are telling thyroid extract is a bad drug without any studies. So that led us to the studies of examining T4 and T3, and this is done by mainly by Dr. Hong, and he's a Navy endocrinologist now. And the amazing thing is he can work from 7 in the morning till 11 o'clock in the night, 6 days a week. And he never pays attention to the 80 hours rule. So he did this study, desiccated thyroid extract is used, and so we studied about patients between 18 and 65 years, and this is all enrolled in the military. And we started with about, number was around 78, and we give the medication in capsules, either to the T4 or T4, the desiccated thyroid extract in the other one. Patient did not know which one they were getting it. And then we stabilized the dose by the TSH. Then we did the Weschler memory test. And it takes about 3 hours to do one Weschler memory test. So you had to do 10 hours for each patient, the memory test. And then we crossed over and then again did the study. And then we also at the end looked at the preference, whether they prefer one or the other drug. So 78 patients and 70 patients completed study. And females, of course, they have more hypothyroidism. And these are the baseline parameters: 51 years, cause mostly autoimmune and idiopathic, and post-I-131. And dose of thyroid was 112. So it was not a big dose. And they have normal vital signs when we started the study. And we measured all these things. Neuropsychological measures was done by Weschler memory test. And I have a copy of that. And if you want to try it on some of your colleagues, you are welcome to do that. And we tried to do our own friends, including the young endocrinologists. They don't do that well on that test. And one of the things I think about this is you get bored. When you ask some irrelevant type of things, that's what I think about some of these tests. So you can measure all this. We measure all these levels during the 3 phases of the study: baseline, thyroid extract, and as well as the synthroid. So we did, these are the memory tests: general health questionnaire, thyroid symptom questionnaire, visual world memory index. These are all the visual memory tests. So if you look at it, the heart rate was 74 in the thyroid extract, and T4 was 74. Blood pressure was almost identical, and the weight, actually there was a decrease in the weight by 3 pounds in the desiccated thyroid extract group. And if you look at it, these are all the memory tests. no difference in the memory test between the two groups. So neuropsychological measurements identical. And we look at the TSH if you look at the thyroid extract, the TSH level was actually a little bit higher, 1.67 compared to the T4. And this is something very important to remember. Of course, the free T4 will be lower because it has the T3, and T3 levels are higher in the desiccated thyroid extract. And these are the ones which are significantly different. TSH, free T4, total T4, T3 receptor, total T3, and free T4 by direct dialysis. So no differences in the characteristics of the patient who prefer DT. And so no differences in the neuropsychological measures. Biochemical parameters were identical. The baseline was identical. So this is the dose of the T4 on these patients. And these are the 5 parameters we measured which predict why they like thyroid extract. Thyroid symptom questionnaires, visual world memory index, T3 rest uptake, free T4, and sex hormone binding globally. We have no clue why this predicts why they prefer thyroid extract. And this is the old conversion published in the PDR. And after we published our report, this is the one now recommended, and up to date included this table right now. So in conclusion, 49% of the patients prefer DT in our study. We have again no clue why they prefer it. And 18% preferred T4, no preference in 33% of the patients. And right now we are trying to do a study looking whether the genetic variations can explain this discrepancy regarding the preference. So DT does not cause significant improvement in quality of life. DT costs about 3 pounds weight loss. Half of the patients express a preference for DT or T4. DT therapy may be suitable for some patients. And the other things I always tell our fellows is, some patients demand DT. Either you can give them DT prescription, or you can yourself take Valium. So you have to make the choice. So I will prefer to give them DT rather than take Valium myself. So this is one paper we did that. There are a lot of over-the-counter medication and mail-order medication, thyroid. There is a medication called Thyromine, which has thyroid extract and adrenal extract. So patients buy these things, and we had a patient on Graves' disease. So her mother got some this medication, and she get aggravation of the hyperthyroidism. Graves' disease was well treated with methimazole, and we did a serum iodine levels. It was sky high, and then this has 10 milligrams of iodine she was taking 3 times a day. And same way, patients have Hashimoto's thyroiditis and hypothyroidism. Stable dose of T4, they are doing very well. Suddenly it gets worse. At least ask them the question, what over the counter? And there are medications. Don't take any of these medications. Just take our preparation. That's what they say. So, ischemic heart disease. I always believe in starting very small dose, something like 12.5 or 25 micrograms. Then go every 2 or 3 weeks. Because if you reach about 25-50 micrograms, you can get about 40 to 50% improvement. Patient feel good. So you don't have to go to the full dose even for a patient to feel better. And pregnancy, I mentioned all these things. And in pregnancy, there is trimester specific TSH value. That is in the first trimester 1 and 2, second and third 1 to 2.5. And if you want to look at that free T4, do free T4 by dialysis, because Quest has the normal values, trimester specific normal values. The free T4, you cannot do it because the kit changes every couple of years, and also no one has standardized the treatment. And elderly, this is what I was talking. This is a very important concept. This is published, written by Furth. He's in New York. If you look at it, if you look at this one, H80, and there is a shift to the right side. So if you look at the levels, 7.1 or 8 upper limit is normal for the elderly people. So don't treat these patients unless it goes to more than 10 or 15, something like that. In fact, low TSH in elderly subjects is associated with increased mortality rate compared to somebody who has higher TSH. So if you measure your TSH, if it is, when you are 60, 65, it's low, it's not a good sign. And of course, poor compliance, you can give 2 or 3 times a week. And the military population, sometimes we bring the patient once a week, give them the tablets, make them drink water, then examine the mouth. We have done that sometimes. So this is the yak in Tibet. I wanted to go and touch one of those yak. So the guide with me tells, where do you want me to send your dead body to? Give me your address. Sometimes they can attack. And again, this is the medical school. Graduate the military students, about 120 students, Air Force, Army, Navy, and Public Health Service. And this is, McDonald's has come to Xi'an, China. So this is me in the Tibetan dress in front of the Dalai Lama Palace. So I think this is the old tower built in 1944 by President Roosevelt. So this is the famous National Naval Hospital, now changed to Walter Reed. Okay, now I will stop it.
Just a little presentation. Dr. Shakir, thank you for that
thank
talk
you.
there.
Thank
We
you.
enjoyed it very much. Just as a memento of giving the Furth lecture for this year, we'd like to present you with a desk clock.
Oh, okay.
You can put on your desk to remember
Okay.
ECU by.
Okay.
In addition to having your tobacco stick over the door.
Okay.
I know the time is short. If anybody needs to leave, you're certainly welcome to do so, but we'll take a couple of minutes for questions for anyone who'd like to stay and ask questions. Thank you very much for your attendance.
Thank you.
Shakir, I have a question for you that may be pertinent for some of the primary care physicians.
Yeah.
When patients come on Armour thyroid extract and their TSH is low normal, particularly the elderly patients, are you concerned at all about the amount of T3 in the Armour thyroid extract and whether or not they could get transiently high T3 levels?
Question is whether elderly patients on thyroid extract, if the TSH on the low side, whether we should adjust the dose. I again try to counsel them, about T4 is better drug. If they don't want to listen, if you stop it, they get very mad with you after a couple of weeks. So I usually split the dose, say 30 milligram, 50 milligram, 2 or 3 times a day.
So they don't get a surge in T3.
Surge in the
right
T3. That's what I
dose.
do it.
So that can be helpful also. Any other questions? All right, I want to announce we're going to go up to the internal medicine library on the 3rd floor of the Brody building. We're going to present a few cases to Dr. Shakir. We have a little bit of light refreshments. If anyone would like to join us there, you're welcome to come up. Thank you very much.